These are a few remarks on thoracic surgery at Mount Sinai in response to Professor Neff's, I guess that's N-A-E-F apostrophe S, request about some of the surgeons here. I'm sure there's far more than he wants, and yet there may be information in it he can use, although the summary is not even a summary, but just a few sketchy comments. First, Howard Lilienthal, Lilienthal. Sometime I would judge about 1910, but none of the dates I give are precise. The first thoracic operation performed under endotracheal anesthesia, and as far as I know, it was the first in the world, was performed by Howard Lilienthal, performing a decortication. The person giving the anesthesia was Dr. Charles Ellsberg, E-L-S-B-E-R-G, who later was a pioneer in neurosurgery. But at that time, he was interested in anesthetic methods. I also believe, as far as I can discover, both from Dr. Howard Lilienthal's textbook and from other writings that I've been able to obtain, he was the first to perform a lobectomy for infective disease. Actually, it was a sort of bronchiectasis with suppuration. He refers to that as one of the methods for treating bronchiectasis in his 2-volume text on thoracic surgery. He also mentions that the mortality was very high, something like 47%, I think he said, but that it was at a stage when you didn't have anything else to offer and was probably better than any of the other modalities. Now, this also brings up the perhaps even more fundamental contribution, which was the concept of the organization of the lung in bronchopulmonary segments. The man whose idea that was has been, for the most part, forgotten by most people. His name was Harry Wessler, W-E-S-S-L-E-R. That's W-E, S as in Samuel, S as in Samuel, L-E-R. Dr. Harry Wessler had the idea, from looking at lung abscesses, particularly what was called putrid lung abscess, that there were the segments that did not intercommunicate with each other, and you could divide up the lungs in these anatomical, physiological ways. I know that he had the idea because I've spoken to numbers of people who were around at the time, and although I knew Harry Wessler and even interviewed him, that was in many years later. However, he was not given to writing, and he was mostly given to clinical practice and teaching and stimulating. And he gave the idea to Dr. Amiel Glass, Amiel, A-M, as in Mary, I-E-L, and Glass, G-L-A-S-S, who was a young beginning surgeon at the time. Dr. Glass later didn't go into thoracic surgery, but actually into abdominal surgery. But he, Dr. Glass, then made the study, including injected models of lungs from the autopsy table, and was able to prove that concept. He also involved Dr. Rudolf Kramer, K-R-A-M-E-R, in the work. Dr. Kramer was a otolaryngologist who did bronchoscopies. Now, their paper is on that idea, and it was the introduction. When I interviewed Dr. Wessler, he referred to Dr. Glass, never even referred to his own work on it, because, first place, his memory was not of the best at the time that I interviewed him. He was quite ill in the hospital. But also because it was characteristic of him, although he liked to take credit for things, when he stimulated somebody else's idea, or when he set him going, he gave those persons full sway and considered it their work. But I think the real credit should go to Harry Wessler as the originator of the concept. Otherwise, nobody would even have worked on it. This also has bearing on the surgical treatment of putrid lung abscess. These abscesses, as you know, were not uncommon, particularly after tonsillectomy and other upper respiratory procedures, and sometimes even after other operations under anesthesia, where bits of the oral cavity and elsewhere were either inhaled or made their way into the bronchopulmonary organ. These were desperate conditions, and they were only treated as chronic disease. In fact, when I was a medical student up at Columbia College of Physicians and Surgeons, the idea of treating them any other way had just been introduced, and it was mentioned to us in a somewhat derogatory way. But usually, as you know, these were long-standing things, and you waited until the parietal pleura had become adherent to the visceral pleura, because otherwise you would get spillage, and there would be either certain death or a high probability of death. But it was Harry Wessler's idea, and then it was both echoed and agreed in by others, such as Harold Neuhof, Neuhof, and others around that group, that the abscesses were at the periphery, and therefore that very early the visceral pleura over the abscess and the parietal pleura were adherent in that area, and you could drain it if only you knew where it was. And so Wessler and Neuhof, and particularly Dr. Coleman-Rabin, Coleman-Rabin, worked out a means of identifying it, because by this time X-rays were being used. They would, by means of study of the X-rays, try to localize where the abscess might be, and then inject in the skin over that area where they guessed it was, a mixture of Lipiodol and methylene blue, and then re-X-ray. The Lipiodol, in the various views of the chest, would then show where their guess had been in relation to the abscess, and then they would therefore be able to tell where it was. The methylene blue was what you would see when you made the incision, so you knew where you were. And if you found that the methylene blue was a little removed if the Lobectomy was, its bolus was a little removed from where you should be, they would measure that, and then when you made your incision on the skin, you would do it in the distance from the methylene blue or directly into the methylene blue. By my time, you could, the methylene blue method in Lobectomy was so precise that we used to make the incision right into the methylene blue. And then you would go right in to the interspace, put a needle in, and if you were in the abscess, suck out some, and then a cutting edge groove director was slipped alongside the needle, and then you were in the cavity, which was usually relatively small by that time, so early, and then either unroof it or make a cross and then pack it, and you had drained an abscess which had a high mortality before then. But it rose out of the concept also of the bronchopulmonary segment. Harold Neuhof played an important role in that method in the surgery of that method, of that condition, working with the others. Harold Neuhof also, it might have been in 1940, I'm not sure, tried, together with Arthur Abscess Sr., I call him because the present head of our department is Abscess Jr., spelled A-U-F as in Frank, S as in Samuel, E-S as in Samuel. Together they tried a transventricular pulmonary embolectomy. I don't really know how successful it was. I believe somebody told me that the patient had survived, but I can't offer that as a fact. At any rate, as far as I know, it was either the first or one of the earliest. I think you probably know about Dr. Turoff, who operated on the first infected patent ductus arteriosus, but this was done at Beth Israel. Dr. Turoff was on the service here, and that was where his main base of operation was, here on the surgical service at Mount Sinai. But that actual operation was done down at Beth Israel Hospital. It was a ligation, but a ligation and actual transection. Patient who had developed positive blood cultures and what we would call septicemia, and all stopped when that was performed. That, I believe, was the first. We also had somebody here by the name of Yankauer, Y-A-N as in nobody, K-A-U-E-R, who had developed some of the techniques of endoscopy, and the suction instrument that he devised is still used and called all over, wherever I've been, the Yankauer suction. It was used for, all over that I've seen, not just in the thoracic operations, but even more often in the abdomen and in the neck. But he was a otolaryngologist, and his precise contributions I am not sure of as they relate to thoracic surgery, except that I know that he was trying and succeeded sometimes, I understand, but not as effectively we know as it could be, to drain suppurative collections in the lung through the bronchoscope and to treat bronchiectasis by bronchoscopic aspirations. since these were the early times of these, he may have been one of the first to do something, but he was certainly one of the pioneers and was very innovative in devising tools for doing this. John Garlock, whom you asked about, actually made a contribution which is not always recognized, and that was a muscle flap to close a bronchopulmonary fistula. Now that may have been in the 20s or late 1920s or maybe early 30s, but I'm not sure. And that was devised in a method of bringing a muscle flap down into the chest, and it was really, in a sense, just stuffing it in to the open fistula. He was also, of course, one of the early workers on esophagectomy for carcinoma. Of course, he was one of the early ones performing lower esophageal carcinoma operations. Since I was his, I could call it private assistant, although I was in private practice myself, shared offices with him and assisted him on the more difficult cases, I can say that he did a fair number, and he developed a technique. Whether he was the first or just one of the earliest, I can't say. As you know, Dick Sweet in Boston was also working in the same field, and the priorities are something I can't say, but I can't speak on. But I do know that this technique which Garlock used was used by many others thereafter. It used to come to watch him, and he used the instruments others had devised. There was for example, a rib spreader that had been used by an Argentinian, Finocchieto, I think is the name, which he took up and then modified a bit, and developed a technique of preserving the blood supply to the proximal end of the anastomosis of the esophagus to the stomach. We had to be very careful of those fragile blood vessels, and he developed a way of preserving them. And we used various principles in placing the opening into the stomach, so we were sure to be on an area which was well supplied with blood, because sometimes if you brought the stomach segment up a little high, the very tip might have compromised blood supply. That's why he buried those tips with numbers of layers to make sure that if there was any necrosis that developed, it would be covered by seromuscular layer. But he may have been either the first or one of the first to have brought the esophagus up above the arch of the aorta in resections of the mid-esophageal carcinomas. Now, he used a left-sided thoracic approach, always. And while he did a few right-sided approaches later because others had written about it, he always preferred the left. For a higher lesion, he made a thoracic incision. For the lower lesions, he made a abdominothoracic incision. And the esophageal anastomosis above the arch was done, therefore, with the left side up and the right side down on the operating table. And so when I can't speak of in front of or behind or sort of really lateral to, the arch is where often the anastomose was placed, although it was tried to be above the arch of the aorta. Now, this was all right for carcinomas that were just below the arch or just above the arch, but the carcinomas at the level of the arch were rather difficult to free and yet not injure the arch. And I never did one. He did, and he did number, and he used to make that dissection seemingly mostly blunt, except for cutting the adventitia. And therefore some of it had to be almost blind, although you could pull the arch up a little and the esophagus down. Of course, I should imagine as a cancer operation, I think it was probably better from the right, as I subsequently was part of at other times in the later years, because you can take out more tissue with it and so on. But for the time, when I watched Dick Sweet operate, I didn't notice that there was very much added tissue around the esophagus that came out from the right side and from the left, though I think just in the nature of the approach, I think it probably did remove more tissue. The anastomoses were all two-layer anastomoses, open, as all the anastomoses we were doing at that time in this institution, started by A.A. Berg, with serosal layer posteriorly done first. This was not the esophagus, of course, but I mean in those hollow organs that had a serosa, and then seromuscular layer, all that posterior, and then anteriorly again the seromuscular, followed by another seromuscular. I mean anteriorly with a mucoso seromuscular, and then a seromuscular over that. But in the esophagus, he would anchor the esophagus by a layer of interrupted sutures between the wall of the esophagus and the seromuscular layer of the stomach before opening the stomach, after selecting the area. And this was placed rather precisely, and then at a distance from that layer that had already been designated as a good layer with good blood supply, a hole, you might say a circle, not even an ellipse, and the circle of the stomach was excised, the blood supply controlled, and then the mucosa and seromuscular layer to the wall of the esophagus was also made before opening the esophagus. I should have said that he made he anchored the esophagus to the stomach before opening it. It therefore had was held up because it was used as a traction with the lesion wrapped in gauze and towel, held up so that you could hold it with traction, and then it was transected after it was placed. Then you could see what retraction occurred and so on, and then the anastomosis was made. And while there had been a few leaks, there were leaks, not many, and I think reported somewhere our experience was as shown. And I can say that since I was the one who collected the figures and the statistics and so on, I can testify to the fact that they are as accurate as I was able to obtain. The chest was drained by a tube underwater. And, at first, there was no suction used. I don't think anybody was using suction at that time. I'm not sure. But that was our method. And then, of course, later he brought the stomach up into the neck and made anastomosis there, as others did. I'm not sure what chronologically was his role. It was certainly one of the earliest. One of Dr. Garlock's contributions that is difficult to measure was his influence on others to use unhurried and yet unwasted movements in performing operations. Everything he did looked elegant and clean. He was considered a fast operator, but it was not the rapidity of his movements, though they were fast enough, but the fact that each movement did something, and there was no wasted time. One other person I want to mention is a contemporary, Paul Kirschner, Kirschner. He may have been a pioneer contributor to thymectomy for myasthenia gravis. He may have written the first paper on transcervical thymectomy for myasthenia gravis, and that might have been in 1967 or 1969. It's curious, though, that Kirschner was still practicing now, after much experience with the transcervical myasthenia, thymectomy, has gone to a transsternal approach. After many studies, he has concluded that you can't get all of the thymus out through the neck, and you can't see all its extensions. And so he now does the transsternal approach.